Good morning, good afternoon, and good evening, everyone. And thank you for joining us for the webinar, Establishing the Case for Prioritization of Life Course Immunization. This is the first of a two-part webinar series called Advancing Equity in Adult Immunization. My name is Anusha Khan. I'm a program manager at the International Federation on Aging, and I'm honored to be leading this important webinar series. Before we begin, I will briefly review housekeeping. We will begin today's session with opening remarks, followed by presentations from the speakers, and then a moderated discussion. We value your engagement throughout today's discussion. Please use the chat function at the bottom of the screen to ask any questions, and during the discussion portion of this event, I will pose your questions to the speakers. We are honored to be joined today by key experts, including Mr. David Sinclair, Dr. Salah Al-Avedi, and Dr. Parvez Kao, to have a discussion on establishing the case for life course immunization. The International Federation on Aging has for over a decade been working to improve the adult vaccination uptake rates globally by hoping to help influence policy and practice change, and working across sectors and disciplines to drive the agenda of the world's aging populations. The work around immunization is based on three pillars of action: prevention, access, and equity. This includes prioritizing immunization as a key pillar of expanded prevention strategies, removing barriers to access to ensure all people are protected and no one is left behind, and equity through timely and affordable access to vaccines throughout life. As we know, vaccination is one of the most successful public health interventions of modern times and a key contributor to healthy aging, as well as preserving functional ability. Vaccination also reduces burden on healthcare systems and expenditures by avoiding millions of dollars in disease management and loss of productivity, providing an economic case for prevention. Several vaccines are recommended specifically for older adults and those with chronic conditions who are most at risk for serious complications from vaccine-preventable diseases. Yet, despite clear evidence in support of life course immunization, the approach is not implemented, as is illustrated through national immunization programs that are largely pediatric focused. And adult vaccination, access, availability, and uptake rates remain suboptimal among at-risk populations. There is an urgent call for action to prioritize adult vaccination and life course immunization to support healthy aging. With this webinar, we bring together representation from diverse sectors as well as leading experts and thought leaders to discuss this important topic and key actions to drive change. The purpose of this webinar is to establish the case for life course immunization and the implementation of this approach through national policies, including a comprehensive national immunization program. I would like to introduce the first speaker for today, Mr. David Sinclair. Mr. Sinclair has worked in policy and research on aging and demographic change for 20 years. He has a particular interest in adult vaccination, active aging, and the role of technology in an aging society, as well as strong knowledge of UK and global aging society issues. He has worked as an expert for the Pan-European Age Platform for 15 years and is the former vice chair of the government's Consumer Expert Group for Digital Switchover. For 10 years, he chaired a London-based charity called Open Age, which enables older people to sustain their physical and mental fitness, maintain active lifestyles, and develop new and stimulating interests. Prior to joining the International Longevity Center, he worked as the head of policy at Help the Aged. Thank you, Mr. Sinclair, for joining us today and kicking off this important discussion, and the floor is now yours.
Great, thank you very much, and good morning, or afternoon, or evening, depending on where you are in the world. So I suppose what I want to talk about sort of the next 15 minutes or so is, and you'll know some of this, maybe a lot of it. Clearly, we live in an aging world. We're getting older, but actually we also know that increasingly we're not aging very well, and that health inequalities across the world is a huge challenge. As Anusha said, the prevention of ill health is increasingly important, and as part of that, adult vaccination is part of the solution. But I suppose I want to pick up on a bit, in particular, on some of the work we've been doing around the economic case, both in the UK and across the G20. Why is this important? And then I'll jump on at the end with some ideas. But a particular message for me is that there is a real economic case here, as well as a health case for action. So for those of you who don't know us, ILC in the UK are the specialist think tank on the impact of longevity on society, and we're a member of the ILC Global Alliance. So there are 16 different ILCs across the world. And we work collaboratively with those, as we do with the International Federation on Aging. My declaration of interest, I won't say very much, but we tend to be supported by unrestricted grants to support our research and a policy agenda. And we also work in the UK with a number of different charities and companies to promote the importance of adapting society to the fact we're all living longer lives. Starting point, and you'll know all this. The world is aging. We're all, everywhere in the world is the population age is increasing. The image up in the at the top left of the screen, some of you may have seen before, but this is a gift that used to be given in Japan for people on their 100th birthday. But because there are now so many people who reach 100, the Japanese government initially reduced the size of the size of the gift, and then turned it from, I think, silver to wood. And actually, I'm not even sure you get it anymore. But actually, and the image of the and then I suppose so on the one hand we have this situation where we're all living much longer, and particularly into much older ages than the past, but also, and there is very much a sort of UK and saying around sort of frog in warm water, which is that if you put a frog in warm water and then boil it, it essentially dies. But if you put it in boiling water, it jumps out. And one of the issues we have, I think, with preparedness for longevity is that in places like the UK and France, the US, Canada, we've actually been aging over about 300 years. So we've been aging over a very, very long time. So there hasn't ever been a sense of urgency in terms of how to adapt to the challenges of aging. Whereas in some other countries, I've looked at places like South Korea, where you have very fast aging, rapid aging, there is more pressure on governments to act sooner and quicker. So clearly, the context is we're almost everywhere in the world is the population is getting older, and we don't really know what the future holds in terms of health. On the one hand, you've got this real fear around the risks of antimicrobial resistance. On the other hand, the potential of polypills and other interventions that could improve our health. But then you have the uncertainty and the issues like COVID, where we saw sort of very significant impact on health across the whole world. But on the other hand, I think it's worth saying that a lot of this stuff is predictable. So ILC ourselves, we published a piece of research just a couple of months before the COVID pandemic started to sort of emerge, which highlighted the fact that a pandemic was likely, and we clearly weren't the only people saying it, but it was really clear that we were expecting a pandemic, and that governments needed to be thinking about how they adapted systems to with that context. Of course, what we know is that we're living longer. Yes, health and medications are uncertain, but we do need to stay healthy. What's really clear is we're not very good at looking after our own health, and I love this stat that people from the UK spend twice as long on the toilet as they do exercising. And what we know is we don't eat the right foods. We smoke and we drink too much. Our physical activity falls as we get older. So we know that there is a message that for all of us with longer lives, we need to stay healthier, but we're not actually in many places very good at it. What we know at a societal level, though, is firstly, there is a very significant return from prevention. So the productivity loss, for example, amongst the richer countries in the world is about $1 trillion for amongst those aged 50 to 64. So huge loss to our economies as a result of us not keeping ourselves as healthy as we could. And then turning it round, actually, and jumping into the sort of area of vaccination, it's very clear that there is an economic case, an economic imperative for action. So the work and the modelling we've done in this area shows that, and let me summarise it. The best way of summarising it, saying that if we support prevention, if we keep people healthy, and very specifically in the case of vaccination, there is even a correlation with flu uptake in this. So if we prevent ill health, people work longer, they provide more care, they do more volunteering, and they spend more money. There is a massive association between keeping us healthy and economic success. So I think we've got the numbers to make the economic case for the prioritization of adult immunization. Also, that the point I've got at the end, older people are actually more likely to be looking after their grandchildren, where you have in countries where you've got healthier populations, so healthier older populations. So very strong economic case. In terms of work, we did some very specific piece of work, again in better off countries, looking at influenza. The influenza in better off countries costs about 160 million working days. The economic, and we calculated the economic impact of flu in lost productivity, the equivalent of 39 billion US dollars. So huge economic cost and an economic opportunity there if we do invest in vaccination and prevention. More broadly, the work we've done on prevention shows that there is an association between spending on prevention and consumption. So we know that the more governments spend on prevention, the more people spend. We know that and I touched on this a moment ago, 10 more volunteer hours per older person per year as a result of, in areas where you see increased prevention spending. And McKinsey have estimated an economic return of $2 to $4 for every ward in improving health. So very, very strong evidence of the economic return and the economic case for prevention. But actually, it's clear that prevention is still perceived as being a nice to have rather than a need to have. So you see the rates of spending varying significantly by country, with places like Canada spending actually relatively high amount, but some other countries spending much less on prevention. And that's in terms of per capita. Of course, there is also a question, which I'll perhaps come back to, around prevention as a proportion of prevention spend as a proportion of actually no, they're both on those. But so prevention per capita is on here, but also prevention as a share of current health spending. So, and it's really important we think about both of those issues. So making sure that we're spending per capita, but also we're making sure we're investing our health budgets on prevention. So interestingly, if you look at Canada, what we've seen is since they have introduced a 6% spending target in terms of prevention, and you've seen a steady decrease in avoidable mortality, increase in life expectancy, and one of the OECD's highest 5-year survival rates for example, lung and breast cancer. So very, very strong case for it. And yeah, actually, what we know, and coming on to the discussion, uptake of adult vaccines is not always as high as we'd like. We did some work last year looking across adult vaccines. Most people didn't know, for example, they needed the pneumococcal and the shingles vaccine. Real barriers to interestingly, the barriers to receiving the flu vaccine were slightly different to the pneumococcal and shingles, but actually, clearly the case that there are some very, very strong reasons why people don't want to and aren't vaccinated. So with that sort of context, and let me just jump to some final things. What can we do? And we heard a little bit about this before. Very, very similar to the areas IFA are talking about. We can invest in systems for prevention. We can, democratize access to prevention, which means essentially the equality point. I think we need to engage policymakers, and we need to use technology. And I'll perhaps spend a moment of that on the end. So the first message for me is, can we get all of the countries across the world thinking about, can they spend 6% of their budgets on prevention, and vaccination being a good part of that. In terms of democratizing access, can we do targeted interventions towards groups where uptake is currently low? Can we address access issues for risk groups? Can we remove some of the cost barriers? In terms of inspiring and engaging individuals, clearly, access to information is really important. So things like making sure we've got the right electronic records, making sure it's easy for people to engage, whether that be online booking. We have a thing in the UK called Make Every Contact Matter, where what we do is, every time you go in to see a health practitioner, particularly, say a nurse, they should say, you've come here for X, have you had your pneumococcal vaccine? And it's really important that we use the whole of the health infrastructure to support these interventions. And then using technology, how do we use technology? Some really, really interesting sort of ideas out, whether that be using WhatsApp, using sort of fixed technology in the homes, to sort of motivate and engage us all around this. Google Flu was a really interesting initiative where it highlighted uptake of it highlighted the extent to which there was flu incidents across the world, actually, and they were quicker than the government in doing this. But to give you another specific example, using real-time data to monitor uptake of vaccination is extraordinarily important, and the UK does this with flu. It allows you to manage where things might be going wrong, and then finally use social media. And I just, for my last slide, was going to talk about a little project we did last year on where we did some Facebook advertising, and we talked to older people. We did some qualitative and quantitative interviews, and essentially designed 5 different campaigns that we used real people. We created adverts that were trustworthy, conversational, family oriented. We had family members talking together, and we designed them based on the research. So very much based on the feedback we got. One thing clearly that is a really interesting piece here is that clearly, and there's a quote down there at the bottom, when you do things like Facebook adverts, you do get a lot of comments, some of which are negative. But actually, interestingly, one of the things we found was that when people were putting negative comments, someone else replied with a positive comment, and were actually drowned out. So and it ended up increasing the visibility of the adverts. And just to say, sort of in terms of our impact, we had 1 million people who engaged with the adverts for which was an all-in deprived parts of the UK. And this wasn't just 1 million people who saw it; these were people who liked it or clicked on it or commented it. So we had huge engagement, and almost everyone who saw the advert engaged with them. So 3/4. And the click-through rate was 2.5 times higher than other healthcare adverts. And we calculated it would have been a cost-effective way to reach older people in deprived and Black communities. So I just wanted to highlight that as an example of where we did some really practical work that did show that you can use some of these tools to make the positive case. So I'm going to come back to my conclusion, and so we've got plenty of time to talk. We live in this aging world. For me, prevention is really important. We need to think about the economic imperative. But there are things that we and governments could do to improve the situation. So I am going to stop there, but thank you very much for listening.
Thank you so much. Thank you for that excellent presentation and insight. So, you mentioned right at the beginning that we live in an aging world, but we aren't all aging well. And that is a very important consideration to bring forward. Is, as we know, globally, the population of adults is growing at an unprecedented rate, along with the prevalence of non-communicable diseases. So really, there is that urgency to prioritize prevention. And as you said, not as nice to have, but need to have. So really building on that economic case for action. And you also mentioned the need to democratize access, utilize technology, and win hearts and minds. So really wonderful insights to bring forward to this discussion. I will now introduce our next speaker for today, Dr. Parvez Kaul. Dr. Kaul is the head of internal and pulmonary medicine and chief of clinical research at the Sherry Kashmir Institute of Medical Sciences in India. He is a medical doctor and was ranked in the top 2% of Stanford University's list of global researchers for 2020. He is a member or fellow of the American College of Physicians, American College of Chest Physicians, Royal College of Physicians London, Indian College of Physicians, and also serves on the National Advisory Group on Immunization and Ministry of Health and Family Welfare with the Government of India. Thank you so much for joining us today, and over to you.
Thank you, Anusha, for that very kind and very generous introduction. And thank you, IFA and Vaccine for Life for having me as a part of this program. Can you see my slides?
Yes.
So giving me the opportunity to talk about the, establishing the case for prioritization of life course immunization. And as David talked about, that we are aging, as Anusha also said, that older adults are increasing in number largely because of modern medicine, nutrition, better hygiene. We enjoy greater longevity and a greater quality of life. And this is true across the globe. And I'll be giving you mostly a snapshot of what is happening in India. And India, we expect by 2030 that at around 8.5% of our population will be more than 65 years of age. And given the fact that India is the most populous country in the world, so these would be whopping numbers. And in the US, we know that by 2035, that with the first time in the US history that older adults are projected to outnumber children. And by 2060, you would have nearly 79% of the children, whereas adults more than 65 plus would be 94%. And once we age, we all know that we have difficulties in our functional ability. The intrinsic capacity goes on increasing, even though there is a wide range throughout life. But individual health outcomes are mainly in terms of intrinsic capacity, and it goes down, though you enjoy it variably. Healthy aging as a concept is defined as something that's a process of developing and maintaining the functional ability that enables well-being in older age. And that's what is very important, is that the focus has shifted from something, an old person being free of disease, to somebody who is functioning well. I live in India, and this is where India is in the South Asia region of the world, just north of the equator, and it is surrounded by low and lower middle income countries, and India is one of those. So in 2017, we tried to look at what is happening to India. I mean, India is doing very well in terms of its economic growth, in terms of its foray into IT and other manufacturing sectors. And we looked at the health of the nation within the nation, and that was published in The Lancet in 2017. And we found that the life expectancy in India increased from 1990 to 2016, and the average life expectancy in males rose to around 67, and that in females to 70 years. Whereas there was a parallel reduction in the mortality trends in under 5 and under 1 age groups, which was primarily because of increase in the quality of care given to the pregnant females and the young children. However, if we looked at what caused the most premature deaths, as Onisha was speaking, non-communicable diseases started figuring out as of the top 3 or 5 causes of death, that is ischemic heart disease, chronic obstructive lung disease, and cerebrovascular diseases. However, even in 2016, lower respiratory tract infections and diarrheal diseases continued to occupy the 2 important slots in the top 5 causes of premature death in India. India is also the diabetic capital of the world, and you expect the numbers to be 134 million by 2045. And that itself gives you a high volume of adult population, the elderly population, as well as those with comorbidities. And the population projections, if you look at various states as given by the report of the technical group on population projections in November 2019, in 2036, only 20% of the population would be less than 15 years, whereas 27% of the population will be older than 50 years of age. And as we know, all that aging is associated with immunosenescence, dysregulated and impaired functionality of immune cells, be it a drop in the replicative capacity of T cells, reduced hematopoiesis, reduced numbers of B cells, near absence of natural killer cells, reduced phagocytic and chemotaxic capacity of the neutrophils, impaired functions of nearly every single organ system in the body. And there's a basal high inflammatory activation, which is also termed as inflammation, and there's a skewing of bone marrow progenitors towards the myeloid series rather than the lymphoid series. And we all know that advancing age can increase the risk of infection. In this particular case from ILO, published in 2019, they looked at the hospitalization by herpes zoster per 100,000 residents stratified by age. As you can see that as the age advances, the risk of hospitalization goes on increasing. And we know that aging is always associated with comorbidities. If you look at UK adults from 45 to 64, nearly 1/3 will have at least 2 chronic medical conditions. And if we go way beyond 65 to 84 years, nearly 2/3 of the people would have at least 2 chronic medical conditions. So the mean number of comorbidities in patients who are aged 65 to 84 is 2.6, and more than 85, it is 3.62. And we know whenever there is a comorbidity, there is a high risk of infections and hospitalizations, and be it COPD, asthma, it ranges 1.3 to 13.5 times, chronic heart disease nearly 3 times, and diabetes, the risk of hospitalization is 1.4 times. The presence of multiple underlying medical conditions increases the risk of invasive pneumococcal disease. And as you can see in different columns and different colors, the blue ones are at 1 risk factor, 2 risk factors, and the ones in yellow are the 3 risk factors, and the green columns are the ones at high risk, which includes those who are immunocompromised, have an immunosuppression because of disease or their medications, or who have conditions like a cochlear implant. And as you can see, as the age advances, your risk of developing the IPD is very, very high. And of the 10 top great public health achievements that have happened vaccinations probably occupy the top slot. And as you can see that all the vaccine preventable diseases have been reduced in morbidity and mortality, specifically in the developed countries from 90 to 100%. You talk of smallpox, where you talk of eliminations, and there's near elimination of many diseases from the developed world. So vaccination has been an important component of achieving this. However, unfortunately, vaccination, the diseases targeted by vaccination are often forgotten. People don't highlight that more than 2.5 million deaths are prevented by vaccines, but they focus on side effects. They do not talk about the non-infectious advantages of vaccination. For example, we don't talk about influenza and pneumococcal vaccination reducing your cardiovascular mortality and myocardial infarction by as much as 56% and 17%. We don't talk about herpes zoster vaccinations being associated with a reduced risk of stroke. We don't talk about rotavirus vaccination reducing the incidence of childhood diabetes by 17 to 35%. And people don't recognize that beyond mortality and recovery, adverse post-infection outcomes like neurocognitive decline, acute sarcopenia, functional decline, and gut dysbiosis is all preventable by vaccination. And for some reason, adult vaccination in most of the lower and lower middle income countries has not taken root, because as Anusha was saying that immunization has been pediatric focused in most of the countries. However, so life course immunization is a concept of vaccination providing protection and health benefits to people throughout their lives at different stages and in different circumstances. And it's more important in the older adults because they harbor a number of comorbidities, and that makes them more vulnerable to infections and their adverse outcomes. This is vaccinations for all ages, and this chart shows the vaccine coverage by various WHO regions globally for vaccines. And you can see, though these are the vaccines that are included in the Sustainable Development Goals, you can see that the HPV vaccine, the PCV vaccine are certainly not optimal. These are 4 studies wherein I have summarized a few of the studies that we have done to understand the uptake of vaccination of influenza and pneumococcal vaccination in diabetics and chronic obstructive lung disease in pregnancy and in heart failure in India. And we have in all of these studies, we have demonstrated that whatever the underlying condition, the vaccination uptake of influenza as well as pneumococcal vaccine was very, very dismal. And we know that vaccines are not fully effective in the elderly because they are primarily being developed for children and immunocompetent individuals. However, assessing vaccine efficiency in the elderly has been difficult, but these gaps are getting filled because of the use of outcome measures with low sensitivity. There's a study bias in immunosenescent defects also are operative in vaccines not be fully effective. And then there's a history of natural exposure to infections, reducing the baseline immune status of an older individual. So what are the various interventions that can be used for reduced response to vaccination? You might increase the vaccine antigen dose, give a booster, use an adjuvant, change route of administration, or use a different platform for vaccine development like a vector-borne vaccine. Healthcare workers are very important in modulating your vaccination uptake, and we looked at the knowledge, attitude, and practice about seasonal influenza vaccination in Kashmir, and we could actually interviewed 1,400 plus healthcare workers and asked them, have you ever taken the influenza vaccine? And only 4.54% of them had actually been vaccinated, despite the fact that all of them believe that influenza is a serious and a potentially life-threatening disease. And they give a variety of reasons for not having gotten vaccinated previously, saying about giving misperceptions and misconceptions about vaccine safety and vaccine efficacy. Somebody saying that it can weaken the immune system, and internet site indicated the vaccine is unsafe. So COVID came and the vaccination, the attitude towards vaccination changed. However, we wanted to find out if that has actually translated in the increased uptake of vaccination of influenza vaccine among healthcare workers. And this time we recruited 789 healthcare workers in southern India. And the uptake of vaccination was nearly 71%. That was very encouraging. However, the overall vaccination uptake dropped to 36% when those individuals who took vaccine as a recommendation of a pre-employment requisite were excluded out of it. So vaccination coverage, even in today, is still at an unsatisfactory level. And the biggest barrier that we believe to influenza vaccination in pregnant females in India is a poor sensitization of the care providers, because we did a study on 1,000 pregnant females. There was none who had been vaccinated against influenza, whereas once we asked them about another vaccine, that's tetanus toxoid and hepatitis B, all of them were vaccinated against those. So which roots the poor vaccination uptake to the prescribing practices of their own obstetricians. And vaccine hesitancy and its determinants are very many, be it contextual influences, conspiracy theories, negative exposure to media, lack of information, vaccine safety, and then there can be vaccination and vaccine specific issues like access, financial costs, lack of recommendation. And then there is vaccine hesitancy, and as David was talking about, the outreach increase using the social media. We have from Google to now AI and chat GPT, and there has to be a cross-generational outreach. An old person may not be as comfortable with TikTok as he would be with Facebook and vice versa. So life course vaccination, we can apply the P4 concept, that is, they have to be personalized, like whatever the disease you have and whatever your risk at higher risk that you are at, they can be predictive. You have to introduce the concept of herd immunity, ask them the antimicrobial resistance, which is a burgeoning problem across the world, can be prevented by introducing vaccinations, because that is going to translate into reduced infections. Then there's a possible infectious etiology of dementia. Vaccination participation has got to be participatory intake. There has to be an increase in health literacy and vaccine literacy. And we should not neglect psychocognition or transcultural differences, beliefs, cultural hurdles, emotions, fear, mistrust in government, access to a glut of information, or should I say misinformation, and celebrity opinion, all moderate. And as David was talking about, there is a lot of value in vaccinating, and $1 investment translates into a return of investment of around $54 in terms of the return of investment on by Gavi. And the barriers that are important for vaccination in India would be an inadequate surveillance of diseases. There are multiple guidelines, and at times there's absence of national guidelines. The Universal Immunization Program of the country does not include adult vaccination as a part of its immunization. Then there are barriers of access, then elderly neglect, missed opportunities, vaccine hesitancy, and lack of healthcare professional recommendations. And there can be vaccine stockouts, travel restrictions, distances to healthcare centers, limited opening hours, inconvenient booking systems can all play a part in your vaccine access. But these barriers also give us a reason for various opportunities. I mean, inadequate surveillance can be tackled by epidemiological studies, network of collaborating institutions, vaccine awareness campaigns, harmonization of guidelines, gaining public trust through information transparency, increasing vaccine access point, increasing the healthcare professionals' preparedness, cost-effective analysis, and older adults have a role in society, and that's got to be emphasized. Today, it was a heartening news to know that HPV vaccine has been introduced as a part of the Universal Immunization Program in India. So to improve the adult vaccination, we have to develop vaccine pathways, improve our vaccine administration, have qualified vaccinators in relation to the nature and density of the population, have targeted public health messages. Targeted public messages on vaccinations are vital to building and maintaining a healthy society, and understanding and executing the steps to address situational and societal barriers reflecting social determinants of health is very crucial to reducing immunization inequities among older persons. So life course in vaccination in India is an urgent need because of the increasing population and burgeoning numbers of adults, older adults, and those with comorbidities. And vaccination has got to be all through the course of a person's life rather than being pediatric focused. I stop here. Thank you for your listening.
Thank you so much, Dr. Kaul, for your insights. So we already see some key themes pulling through already, including the urgency of life course immunization, keeping in mind the aging populations, as well as the importance of healthy aging. You touched on functional ability and how intrinsic capacity can vary across the life course. At the IFA, we also advocate that the focus of public health strategies, including immunization, should be on targeting people with high and stable levels of capacity and maintaining that for as long as possible. So thank you for that. And also you brought to light barriers to immunization, providing examples from India, and really touching on the impact of inequities on uptake, which must be accounted for and addressed. Thank you also for mentioning key opportunities for actions to implement life course, which is going to be part of the valuable discussion today. With this, I will now introduce the next speaker for today, Dr. Salah Al-Abedi. Dr. Salah is a medical doctor and holds masters in epidemiology, with current post as Senior Consultant Epidemiologist and Communicable Disease Surveillance and Control Advisor to the Office of the Under-Secretary of Health Affairs at the Ministry of Health, Oman. He currently advises on eradication, elimination, and control of communicable diseases of public health importance, in addition to the expanded program on immunization. He was a DG of Communicable Diseases Control, and at a national arena, he played a fundamental role in reducing mortality and morbidity of vaccine preventable diseases for pediatric and adult populations in Oman. In June, he was honored by the CDC as the highest achieving person in Oman, having played a key role in actions around immunization uptake and coverage in his role. And in the international arena, he has represented a number of important global advisory groups, some of which include the Advisory Group on Immunization, SAGE, and the Global Task Team of Pandemic Influenza Vaccine Response. Thank you so much, Dr. Avedi, for joining us today, and the floor is now yours.
Thank you so much, Anusha Khan. Thank you so much. Let me just open the... Okay, thank you again. Thank you, 5A, for inviting me. I highly appreciate that. If I may start with, I would like to also thank David and Parviz for have set the scene nicely. So my presentation will be going very smoothly because I think they've tackled a very interesting and very important issue, how to set it down, the life course immunization at the country level. So I'm really happy for that. And my presentation will be around the life course immunization and integration, as well as implementation and the lesson learned from the GCC countries. A bit of introducing myself. I'm a medical doctor and a MINASAN chairperson. And MINASAN stands for Middle East, Eurasia, and Africa Influenza Stakeholder Network that has been established sometime 2019, aiming as much as possible to assist the member states in looking at the influenza threats and in a number of other issues, assisting the member states in strengthening their national pandemic influenza preparedness and response capacity, and assist the member states in research capacity to in the area of influenza, and particularly improve the influenza vaccination practices, as well as advocacy and informed communication. So this is what we are doing in MINASAN. Going back to our presentation, many of you know that the Gulf Cooperation Council, what we call GCC country, is an intergovernmental organization made up of 6 member states, namely Bahrain, Kuwait, Qatar, Oman, Saudi Arabia, and UAE. I'm sure that people are quite aware of Qatar because of Doha. Doha is becoming very famous, and for the UAE, Dubai is a very famous, and Saudi Arabia. This is there are tons of these holy places. So these are maybe 3 countries are very popular globally. These countries, in fact, are considered to be known, considered to be a high-income country with a GDP of around $3 trillion. And the population in these countries has been estimated to be around 54 million people living in this country. And interestingly, that in our countries, we do have 40 to 80% are non-national or citizens. So we have a huge number of non-citizens living in our countries. Well, I will start by say a few things, which is I believe our countries are having a very strong policy with respect to life course immunization. And the policy or the goals in our country is stated as all individuals, whether national or non-nationals, should benefit from recommended immunization throughout the life course. And these should be effectively integrated with other essential health systems in our countries. In addition to that, the policy also stated that to promote the autonomy and independent living of all the person and improve their quality of life, as you have already heard from Pervez and David as well. All these policies are very much aligned with the national health vision that has been established, as you could see, have been established very well in our countries, particularly recently, where we do have a long policy that has been done for the health of individual in these countries. Well, I'll start by going through the key achievement, because these achievements are the pillars by which the life course immunization has been built on it. One of the things that we are really proud of is having a very strong API program, and is considered to be one of the essential prevention pillar in our countries. And in addition to that, we are also having a system, what we call a common vaccine procurement system for all the vaccine for ages now. And these vaccination services and policy being very well integrated into the essential services, namely primary health care and other institutions, inclusive of private sector, because we do have a huge private sector in our countries. And all of these vaccination policies, supply chain are very well in place. So, and over the years, we were able to maintain a very high coverage among particularly among pediatric age group. I could say mostly above 90% for all the vaccine. Almost we have reached 20 vaccine already been integrated into our system, and the vaccination are provided free of charge across the countries. This is the slide that's showing you the individuals that are receiving the vaccines, as well as the type of vaccine and where they receive the vaccine. So if you look at the service delivery platform in our country, you see starting from pregnant women and early young babies up until 5 years. These are very well provided at the primary care and hospitals. And then we have what we call a school-based vaccination, which is started from 6 years up to 18 years with a bunch of these vaccines, and then adult and elderly, where we do have a number of these vaccines have been already implemented at the primary care as well as home visit. I'm going to talk about it a little bit more in a minute. The good thing that over the years, I mean, more than a decade now, we were able to maintain a very high coverage rate among pediatric age group, almost above 90% in these from this, among the pregnancy up to 18 years old. And this is what the fundamental and something that we're really proud of. But the something that we are really worried about, the vaccine coverage rate, despite of availability of these bunch of these vaccines in our system, the rates hardly could reach range between 30 to 50%. And I'll tell you the reason behind it in a few minutes. Well, a few things that we have in place which I believe are quite helpful and do help us a lot to maintain those high coverages, particularly among pediatric age group until a school entry, which is the vaccination are very much linked to the services that they're providing to all these age group. And until school entry, all there is requirement. For example, civil birth registry and the school entry, you will never be able to go without being fully vaccinated. And we do have a very good system of missed opportunity that has been placed over the years, particularly among the pediatric age group, that has been very well established until adolescence ages, and we really are proud of that. And again, among antenatal immunization clinic has been very much linked with the antenatal services that really help us a lot in maintaining high coverage of those vaccines over the years. And the key, again, one of the key achievement in our system is that we do have very strong attack, and as a result of maintaining the high coverage, we were able to eradicate, eliminate, and having a low incidence of a number of these vaccine preventable disease, in addition to having monitoring and evaluation system in place that really help us a lot to reach that target. So what are the gaps, particularly when in relation to adult vaccination? We do experience a lot of vaccine coverage, despite of having almost all the needed vaccine to be given among the adult and elderly. And another issue that I would like to say that inclusion of non-national hasn't been the way that it should be. As I've already said, in our country, we do have 40 to almost 80% of the population. Some other countries are non-nationals, and some of these countries do have a high populations among adult, and mainly adult and elderly as well. And another thing is, it seems to be we are really haven't had that system of missed opportunity the way that it should be have been in place for the adult and elderly as well. Unfortunately, hasn't been placed the way that it should be, like a vaccine to be checked at contact with the health services. Unfortunately, that hasn't been implemented the way that it should be, and that's why we were not able to reach the high coverage despite of availability of the vaccine. We know that the adult and elderly, some of these are going to the highly specialized clinics, and being there, that would be a great opportunity in terms of access to provide the vaccine, and that is not the case over there. In addition to that, some of the vaccine in some countries were not being provided, like PCV, HPV, among others. But otherwise, all the vaccines were really available in most of the health services and free of charge, with the exception of non-national, adult non-national is not the case. So the opportunities, I believe that we need to use the present adult platform that is already exists for the pediatric vaccination and adult elderly that need to be used efficiently, like we do have in my own country, like home visits for the elderly. That system has been established and very smoothly going on. That would be the best way to make sure that the vaccine is being delivered and given, and at the hospital contact and any health system contact, that would be an opportunity to provide the vaccine. As of now, based on the data, we haven't faced a vaccine hesitancy the way that we see other places, and I think this is a good opportunity, but we're really lacking accessibility. If we have that in place, I'm sure that would really boost the vaccines coverage rate in a very, very high rates, whether we like it or not. So the few things that I would like to say as a key message, the system that we have in our countries, the Gulf countries, have really believe that the prevention is the key towards having the people as they growing up healthy. There's no doubt. That's why they provide all these vaccines and excellent services across the countries. And that's really opportunity that need to be utilized and used efficiently. We do have a very strong API program that could really handle, but unfortunately hasn't been the way that it should be, but that's a good opportunity. And a few countries to go ahead and enhance introduction of some of the vaccine for the life-course immunization like PCV, HPV. But I know that very soon, so far for these two vaccine exact, I could say 4 out of 6 countries already introduced among adult and elderly population, and the others will follow very soon. I think by this, I would say thank you so much for your attention.
Thank you so much. Thank you for the excellent presentation on the integration of life course immunization, which is key, and providing as well examples from the Gulf countries. The progress that you mentioned in the Gulf countries is truly impressive, with the importance on the focus on prevention. So I'm sure we can all benefit from the lessons learned and the insights that you presented today, as well as insights on integration and enablers that you can use. In your presentation, you also highlighted some of the gaps that exist, such as inclusion of more populations within the policies in areas where more work needs to be done. So thank you for that, and thank you for your insights. So building on the conversation so far, I'm sure that the discussion today will be very valuable. I do want to open the floor for any questions, and I do encourage everyone to please write your questions in the chat box so I can then post them to the speakers. So please feel free to do that right now. We heard today global perspectives on establishing the case for life course immunization, hearing the European and UK perspective, as well as insights from India and insights from the Gulf countries. So I would like to kick off the discussion with one question that I would like to pose to the speakers as well, which is around barriers to vaccination and the issue as it relates to lack of recommendations for adult vaccination. So we do have recommendations, but mostly pediatric focus, which are obviously very important and essential. But building on that, there is a need to have recommendations for vaccinations at multiple stages throughout the life course. So question being, how do we build a narrative that carries the weight when building the case to invest in life course immunization, as well also touching a little bit on the theme that was brought up constantly around lack of awareness for vaccines, and such that vaccines such as HPV, PCV, shingles don't really receive the targeted attention that they do require. So how do we prioritize these through technology, through campaigns and messages? So I'd love to hear insights on this.
Okay, so thank you, Anisha. That's a very important question, and that's especially important in the part of the world that I come from. And if we talk about adult vaccination, it has not taken root at all in the countries in and around India. And the only adult vaccine that has actually rolled out has been the COVID vaccine. And that was because of a strong political will. But that also gives us an opportunity to understand that if there is a strong political will, then you can probably be able to roll it out. However, there are no universal immunization programs in India that recommend vaccination for the adults. So first of all, we need to understand what is the burden of these diseases. And for that, we need epidemiological data that shows, yes, this is a comorbidity and these are essential to be prevented. And once we have the epidemiological data, then you understand, you actually can push it to the policy planners, and I'm a member of the ANTAGI. And there are other issues after the ANTAGI recommendation, because government has essentially to roll the vaccination program out for the people, and you need deeper pockets for people who are in excess of 1.4 billion. So for that, you need a good economic cushion, which unfortunately is not there, but it is slowly changing. I mean, India was a lower income country, now is a lower middle income country, and probably moving forward. So what is important is that we have to have good epidemiological data. We have to probably show that, and there are groups of people who are being vaccinated by private people, private institutions, and there are very many who can actually afford the vaccine, and they are the ones who will be able to prevent get the disease. I mean, you can prevent the diseases in them, and as such, those can be models to be shown to the policy planners that, look, this is where we are aiming at, and this is what we have achieved by maybe through non-governmental opportunities, and those have been exploited, and maybe you can take a call on that.
Well, this is a really great question. I echo what Parveez said. We need to have as much as possible data to support the case that we have, like border disease and so forth. And usually this is something done by people who really know the things and so forth. That's to begin with. Yes, you need to do that. But there are other issues other things that also need to be in place. We need to empower the adult population itself to know this is their right of vaccination, because you may have the data and everything, and the decision maker are having their own priority and they keep postponing it. But if you have a push from the individual self through their association, whatever, to say this is our right, we need to live in a good life. There are vaccination that's we're supposed to have them, and this vaccination is gonna put us in a much better life than we are now. So we need to empower the individuals. In addition to that, we have a lot of these associations around us to push the issue itself, and to put it in a plate to the authority, because the authority, if you start hearing from many, make a noise from many individuals, they say, oh, I think this is quite important now. And I think in my personal experience, there are many of these vaccines, even in my own country, they were introduced not because of we don't have the data, just they were coming from other than beyond the Ministry of Health, and they were really able to convince the decision. So this is another thing that not to be undermined.
And perhaps I'll just add a very, very specific thing, because I think most of the points have been very, very good points of an opportunity, I suppose, under the World Health Organization Immunization Agenda 2030. Every country should have a national strategy for vaccines. So there is clearly a tool there for us to be convincing policymakers and others to ensure, and I think the opportunity to say, think about adult vaccines, think about shingles, think about the new conditions that, as well as existing ones, and as part of those strategies, think about how you maximize uptake, as well as to look to innovations in vaccinations to improve health.
Thank you so much. Thank you. Sorry, go ahead, Dr. Uribe.
No, what David said is quite interesting. The WHO keep telling us a lot. But again, whether that sort of policy would be able to translate it into the reality, that is not an easy as we think. Every country has its own specificity, and the idea is to try as much as possible and utilize that the policy to make everybody understanding the importance of adult vaccination. That's it. Otherwise, I know that the WHO has done. IFA, you're doing a great job. The other association, they do a good job in terms of promoting. But whether the message has gone across and reached the decision makers or the policy maker, that is something that we need to make sure this is happening.
So if I may add a small comment, I mean, we also have to what David put up an economic case for vaccination.
Yeah.
That is something that is very important for countries like us. I mean, once we talk about not having the enough economic cushion to roll out a vaccination program, we can counter that by putting forth a case that for every dollar that you spend on vaccination, you have a return of investment of say $40 to $50. That makes economic sense, and that's something that might that policy planners might find attractive as well.
Thank you so much. Thank you. I think we touched on a lot of important factors, building that economic case, building the strong political will, and also some challenges that currently do remain as it comes to informing data, collecting data, as well as recommendations and policies, and also empowering adults and increasing awareness. A lot of areas where more work needs to be done, as well as recommendations on how to move forward. There are a few questions in the chat box as well, and just building on to a question that was asked by Shmuel around equity and mixing that with some of my thoughts as well. So can you explain a little bit more about the importance of equity? So even though we can increase awareness, if barriers exist, such as struggling to see a practitioner or complicated pathways or costs, there will still be problems related to impact. So what do you think are some of the opportunities to bridge these gaps, and how do we involve different stakeholders to advance equity?
Yeah, I think, I mean, there are lots of barriers and each needs to be addressed specifically. And I said that there are epidemiological difficulties. We have access difficulties. I mean, there are vaccination centers that are hard to reach, and that is something that you need to do. We have a poor number of vaccinators. They may not be very many. So those are issues that need address immediately. And then there are country-specific issues. And if we talk about the opportunities, we have to increase, we have to gain. What is important that we need to be transparent about the benefits of vaccination, and that has got to be circulated widely through whatever means of communication we have with the people, be it electronic or print media, be it the social media, which is so important these public trust. For some reason, the governmental policies are not trusted always by the people. And this was most apparent in COVID times. And so we need to gain public trust through information transparency. And then we have to fight vaccine hesitancy and anti-vaxxers. We have to actually really sideline them so that whatever misinformation and disinformation they are spreading doesn't take a strong root, because for some reason bad news spreads faster than any good news. So vaccination awareness campaigns, then there's got to be harmonization of existing guidelines. I mean, societies, the physician societies, the medical bodies, they have to chip in with their part and actually recommend vaccines to their people. And I told you about the pregnant females. The obstetricians themselves don't vaccine, and they don't prescribe the vaccine. So all of these actually help build equity about vaccination. Then we have to tell them the cost-benefit analysis as we build a case of economic sense about vaccination, and tell people that older adults with good functional ability have a greater role to play in our day-to-day life than those who are ill and confined to bed or confined to with a limited functionality. So these are areas, and we have to act on each one of those and look at all the barriers and address each one through governmental organizations, non-governmental organizations, societies, and individual efforts.
Thank you so much. Dr. Veli, over to you.
Yeah, I don't think I've got very much to add actually. I think we've just done a piece of work looking at Central and Eastern Europe, and the point that was just made about the issue of trust is extraordinarily important in some countries much more than others. And of course, in parts of Central and Eastern Europe, there is a huge distrust that is historic in governments, and actually that makes it really, really hard. But actually, just to pick up on your point around sort of the medical professionals, absolutely, it's really important that medical professionals themselves are trusted. There's a UK doctor we work with who says one of the things that he does in his surgery is he has a photo of himself being vaccinated in the surgery so that people can see that, and it's quite a nice sort of subtle message, which I think could be really, really helpful. And in terms of the messaging, so we've done both in Japan, in the UK, and across 4 or 5 other countries as well. And it will vary by country how you do this, but actually what we found is messaging needs to be really positive, not negative. So instead of saying you will avoid disease, talking a lot more about the importance of healthy aging and the value of healthy aging and the value of having time to look after the grandchildren and play with the grandchildren. So think about the positive story rather than the avoiding ill health, because none of us think we're going to get ill, whereas we all want to do the positive things.
So one more thing that, Anusha, I wanted to impress upon was what David touched upon was the healthcare providers. And that is very important, that healthcare providers are sensitized themselves, and unless they are sensitized, because they are people in whom people repose a lot of trust, and they are generally believed more than the governmental policies. And there is some reason to that as well. I mean, we have had examples of Lysol being recommended for treatment of COVID. We know that. And those are the kinds of things that came from governments, and that's why people have a lot of mistrust and distrust about governments. So, but one important person who is really, really trusted is a healthcare worker, a doctor. And if he does prescribe a particular thing, it is more likely that the person is going to take the vaccine. And I talked about our study of influenza and pneumococcal vaccination in diabetics, and with the vaccination uptake was 9% of the 1,100 diabetics that we actually interviewed. And once we asked the others as to whether they had been recommended any vaccination by their healthcare providers, none of them had. And only these 9% had been actually recommended vaccination by their healthcare providers, and that is why they took the vaccine. So that is very important, that our healthcare workers are sensitized enough to understand that vaccination, adult vaccination, is very, very important, and it should be rolled out.
Just now, I feel that I'd like to echo what has been said about healthcare workers, and we always think about doctors and physicians. Do not underestimate the nurses. I believe the nurses are really fundamental and have much more contact with our patient more than the doctor themselves. I think that particular group need to be really empowered in terms of information, in the power of all what's really necessary, because they are the one who really, if you go to any clinics that anywhere in the world, whether in a high-income country, low-income country, middle-income, you find staff nurse or nurse are the one who really roaming around the patient, and they can do a lot in terms of increasing awareness, as long as they're very much been equipped with all the information, a positive information, as David said, and they could really convince the patients or the client. And in fact, in our environment, in fact, the nurses are doing job much better than the doctors. And we believe on them much better than the doctors. The doctors don't have a time, and many times they are very fancy. They give a different, but the nurses are very quiet, and they could do a lot of convincing, a lot of job that we are not able to do.
Thank you so much. Thank you for bringing forward all of these perspectives, as well as really highlighting the important role of healthcare providers, including both doctors and nurses, which also we have found in all of our work, they play a key role in informing the decisions. However, the lack of recommendations is definitely alarming. I think when it comes to healthcare providers, it's also important in terms of opportunities and key actions that need to be done to make sure that they have real-time data that is available, that they know how to navigate these conversations, and also important to really have access to providers as well. These are all critical actions to improving uptake. So thank you for touching on them a little bit more as well. We are running out of time with the hour and a half quickly coming up. So I will like to come back to you for key speaker takeaway messages as well. The objective for today's webinar was really to establish the case for life course immunization and the implementation of this approach through national policies. As we have seen through the discussions today, this is a complicated but a very essential conversation, and we certainly have unpacked global perspectives and key actions throughout the discussion today. So coming back to you with key takeaway messages, I would like to start off with Mr. Sinclair.
I think I'll just want to, I suppose, reiterate this, and there's a risk I'll just repeat what colleagues have said, that, in the context of longevity of us all living longer, it's really, really important that we do prevent and do more to prevent ill health. Adult vaccination is relatively easy. It's proven technology. I think what we've learned is there are some really interesting and amazing things going on across the world, but there is this imperative for action, but and actually let's use that going forward to make sure that that as many people as possible are benefiting from vaccination. So I will stop there, so if that's okay.
Sounds good. Thank you so much. Over to you, Dr. Powell.
So I'd like to say that immunization is a global health and development success story, saving millions of lives every year. Vaccines reduce risks of getting a disease by working with people's bodies' natural defenses to build protection. When you get a vaccine, your immune system responds, and that helps you prevent getting a disease, and that helps you getting sicker because of a disease if you get it. So I think there is a case for protecting yourselves, your loved ones, and there's an economic sense in getting vaccinated.
Thank you so much. Over to you, Dr. Avedi.
Thank you so much. Well, maybe what I would like to say in addition to what has been already said, that once you are at the country level, for example, you are able to introduce the vaccine, make sure you have the system good enough to monitor and maintain the success. It's very crucial, because we could talk all the time, we need the vaccine. Once we introduce the vaccine and then the system is not equipped enough to maintain the achievement, and that is very bad to go back, and it's going to be very bad. So I hope and this is very much applied to our Gulf countries, is that we have the vaccines already. There's a lot of investment from the governments, but we haven't done very good in terms of monitoring and make sure that every individual really wanted to be given really has received that. So this is based on looking at the system and make sure that whatever the system that you have has all these elements that is going to make you at the end of the day to maintain the achievement that you wanted.
Thank you so much. Completely agree with that. Very important points that have been brought up throughout the day as they relate to the economic case for life course immunization, but also the health and the social case for implementing this approach through national policies. We also highlighted the opportunities and key actions going forward, which I'm sure is going to bring value. So with this, the discussion for today does come to an end. Thank you so much to Mr. Sinclair, Dr. Avedi, and Dr. Parvez for your valuable contributions to this important discussion. On behalf of the IFA, we would also like to thank MSD, Merck & Co. for supporting this webinar series. The resources for this webinar will be made available on the IFA website. The IFA has also developed a policy brief on addressing adult immunization inequity and improving the uptake rates of adult vaccination among older people, which will be launched and shared soon. Before we leave, I would also like to thank IFA staff and the comms team for supporting this webinar. Again, we value your participation. Thank you so much for joining us today, and we look forward to seeing you at the next webinar in the series. Bye, everyone. Thank you so much.
Thank you.